Hello and welcome to Inside Ophthalmology. I am Dr. Amrit, welcoming you to another lecture. In our previous videos on VKC, we discussed about the pathophysiology and the clinical features of VKC. Today, we shall be discussing the treatment of VKC. This video is targeted basically for beginners, in which we shall be discussing the various treatment modalities, the mechanism of action, the various drugs available, the surgical procedures available, and the side effects. Another advanced video on the treatment of VKC, in which we discuss about the step-by-step approach, how to escalate and de-escalate the treatment of VKC. That video shall be posted in the members only section. Now, if any one of you is interested in joining our memberships, make sure that you are subscribed to our channel and then you click on the join button that appears beside the subscribe button. Okay, let's begin. So, why do we basically need to treat VKC? Ineffectively treated VKC can lead to various problems. We can develop corneal neovascularization, pannus, there can be development of shield ulcer. Shield ulcer in itself can cause various problems. The patient can have astigmatism. Because of constant rubbing of the eyes, he can develop keratoconus. There could be development of amblyopia, and also there can be corneal thinning and perforation. Now, if you want to avoid all these blinding complications, we have to treat VKC effectively. So let us see what treatment options are available to treat VKC. We have non-pharmacological options and we have the pharmacological treatment. First, let's talk about the non-pharmacological option. Here, the first important thing is avoiding the allergen exposure. Make sure that the patient identifies a specific allergen and then try to minimize the contact with that allergen. The allergen could be anything related to food. There could be drug allergy, latex allergy, allergy to insects, some pollens, airborne allergens, even pets, and even some cosmetics and detergents. Apart from that, the patient is advised to take some protective measures, wearing wraparound sunglasses like this, which really provide a barrier, and also these caps with visors. So these will reduce the exposure to dust, sunlight, and wind. Also, artificial tears can be prescribed. So use of this preservative free artificial tears basically flushes out the allergens and inflammatory mediators. Also, cold compresses are advised. Here, you apply them during the acute episodes to reduce itching, swelling, and redness. Also, patient education and support is really important. You have to educate the patient and the caregivers about the VKC's chronic nature. Also, you teach them proper eye drop installation techniques. You ask the patient that after installation of a drop of the anti-allergic medication, they are supposed to give pressure in the nasolacrimal duct area, and this is to prevent the immediate drainage of the drop into the nasolacrimal cavity. So that is very important. Now let's talk about the pharmacological treatment of VKC. Here we have the topical treatment, systemic treatment, and the surgical treatment. First, we'll talk about the topical treatment. Here we have mast cell stabilizers. Then we have the topical antihistamines, dual acting agents, topical NSAIDs, mucolytic agents, topical steroids, and topical immunomodulators. Under the systemic treatment, we have oral antihistamines, oral steroids, oral immunomodulators. Under the surgical treatment, specifically for refractory cases who have these really big giant papillae or who have severe shield ulcers, we can go ahead and with the supratarsal injection of long-acting steroid, surgical excision of papillae, even cryotherapy we do. Superficial keratectomy can be done, and if you do keratectomy using an excimer laser, that is known as the phototherapeutic keratectomy. Amniotic membrane transplant can be done in these cases. Limbal stem cell transplant can also be done if in case your patient has developed one complication, which is limbal stem cell deficiency. Alright, so first we'll talk about the topical treatment. Here, the first one is the mast cell stabilizers. Alright, so we know that the mast cells are basically responsible for the type 1 hypersensitivity reaction seen in VKC. So we talked about the pathophysiology of VKC in detail in our previous videos. Alright, so this type 1 hypersensitivity basically leads to degranulation of all the preformed granules which are present within the mast cell. right? So here the mast cell stabilizers are basically going to stabilize this mast cell membranes, and thereby they are going to prevent the release of inflammatory mediators. And because no inflammatory mediators are now released, it will also prevent the influx of several inflammatory cells in that area, including the eosinophils, monocytes, and neutrophils. All right, now let's see what all mast cells are available. Mast cell stabilizers are available to us. So we have cromolyn sodium. It's available as 2% and 4% solution. Then we have nidocromyl 2%. Then we have N-acetyl aspartyl glutamate, also abbreviated as NAGA 6%. Then we have the lodoxamide 0.1%. Okay, so pemidolast and nidocromyl usually are indicated for the acute allergic conjunctivitis, but cromolyn sodium and lodoxamide is something that is used for the chronic allergic conjunctivitis. All right, so you should know the mechanism of action, you should know the drugs and their percentages and their composition. Apart from that, what is expected at a beginner level is to know the side effects of the drug. Now, mast cell stabilizers will cause basically burning and stinging sensation. However, this is much less than your ketoconazole, which is the topical NSAIDs, right? The only problem with the mast cell stabilizer is that they take some time to act. So usually it takes 2 weeks to 4 weeks for the mast cell stabilizers to work and totally stabilize the mast cell membrane. And that is the reason why the mast cell stabilizers you can't use in the acute stage of VKC. You have to use them prophylactically. For example, when the season of VKC arrives, mast cell stabilizers can actually be used 2 weeks ahead of the allergic season. Alright, next what we have is a topical antihistamines. Now over here in the topical antihistamine category, we are basically using the second generation antihistamines, right? So what do we know that? We know that we have these mast cells, okay? And these mast cells basically act by the H1 receptor. So they have this H1 receptor on which histamine is basically going to bind, and then there will be degranulation of the all the preformed mediators, right? Which will cause allergy. So topical antihistamines will block the H1 receptors selectively, okay? As a matter of fact, they are going to act as inverse receptor agonists. So what exactly is meant by an inverse receptor agonist? So an inverse agonist is a drug that is going to bind to the same receptor as the natural agonist, but it induces a pharmacological response opposite to that of the agonist, right? So, for example, over here, our drugs are going to bind to this H1 receptor just like the histamine, but instead of acting like histamine, it's going to block the physiological effects of histamine. Okay, like the pruritus, capillary dilatation, mucosal decongestion, all of those things which are mediated by histamine will be blocked. And that is the reason why these antihistamines are known as inverse receptor agonist. Okay, so this is going to help you in your pharma as well. Okay, so let's see what drugs we have. We have levocabastin and we have amidastin over here, right? And the importance over here is that the topical antihistamines, they have a rapid onset of action and therefore they elicit much quicker relief from itching and other symptoms compared to the mast cell inhibitors, right? So in your acute episodes, you have to use topical antihistamines, and prophylactically you have to use mast cell stabilizers. All right, so that is one important point. Okay, what about the oral antihistamines? Now, oral antihistamines that are available to us are cetirizine, levocetirizine, loratadine, and desloratadine. Okay, now one major undesirable effect with oral histamine is that they are going to bind to receptor in the unaffected tissues as well, right? So they are going to bind with the histamine receptors present in the brain, in the eye, in heart, and therefore they cause unwanted side effects like sedation, dry mouth, dry eye, and tachycardia. Moreover, they are not as specific as the topical receptor, topical antihistamine. So they will bind with your H2 receptors also, leading to all these complications, right? Apart from that, they are very less commonly used because they take a longer time to act. There's a delayed systemic absorption. So most of the time, if you're using oral antihistamines, they are used adjunctively along with the topical antihistamines. The topical antihistamines generally do not contribute to such side effects because they are not interacting with the cholinergic receptors, which make them a better choice compared to the oral antihistamines. So I hope that is clear. All right, and moreover, if a patient has allergic rhinitis, that means there is a history of atopy, or if there's systemic symptoms of atopy, in those cases you can prescribe oral antihistamines along with the topical. Otherwise, mostly you go with the topical antihistamines. Now let's talk about another class of drugs, and that is the dual acting agent. As the name suggests, they have dual activity or mechanism of action. So they are basically going to combine the mechanism of antihistamines with the mechanism of mast cell stabilizers, right? And moreover, dual acting antihistamine or mast cell stabilizers, they are the most recently developed class of agents, and clinically also it is considered that they are superior in relieving both the signs and symptoms associated with allergic conjunctivitis. Okay. So important thing over here is that they will give you immediate action of antihistamine. That means the patient is going to be relieved of his symptoms immediately. And also it is going to give that long-term benefit, that is the prophylactic action of mast cell stabilization. Okay. Moreover, they have a better tolerability than single-acting antihistamines. So what are the drugs which are available over here? The drugs available here are olopatadine, and olopat is basically available in various concentration as 0.1%, 0.2%, and 0.7%. The 0.1% is used BD, that is 2 times in a day, and the point 2 and point 0.7 are used basically single time, okay, or once in a day. Then we have bipotastin and bipotastin besylate, which is a newer drug, 1.5%. We have ezilastin, 0.05%. And then we have something which is even more potent than olopatadine, the new drug, and that is alcaftadine, available as 0.2%, right? So remember all these points. Then there's also a mention of mucolytic agent, although we don't so frequently use it. Now, the whole idea behind the mucolytic agent, and the agent that we use over here is N-acetylcysteine 0.5%. It works basically by breaking the disulfide bonds which are present in the mucoproteins, that is the mucus molecules, and thereby it basically reduces the viscosity or thickness of that mucus. So not so frequently used in case of VKC. You basically use it in case of your filamentary keratitis or dry eye, in dry eye which is associated with filaments, right? Now, the thing is that since it reduces the viscosity of the mucus, it makes it less sticky and it is easier to clear basically that mucus or fibrin. So, in case of VKC, where are you going to use it? Maybe in cases where you have the shield ulcer with plaque formation, you can use this to dissolve that plaque. Okay, so mucolytic agent over here is N-acetylcysteine, available as 0.5%. Let's talk about the topical NSAID. So topical NSAID basically is going to work on the arachidonic acid pathway product. So what I mean to say by the arachidonic acid pathway product is your prostaglandins and your prostacyclin. Okay, the main drug over here is ketorolac tromethamine, and it's available as 0.3% or 0.5%. Very important is the side effect which is associated with ketorolac tromethamine, and that is the burning stinging sensation on instillation, along with that corneal toxicity with prolonged use, and also sometimes corneal melting. All right, so now let's talk about this arachidonic acid pathway. So before that, you should know how exactly the allergy happens, that is the pathophysiology. So that is available in our previous video on VKC. Nevertheless, I'll just brief you about that. So we have allergens present in our system. Those are taken up by the various antigen presenting cells, and they are going to be presented to the IgE molecules which are present in the circulation, and some of the IgE which are sitting on the mast cell. After that complex is formed, there are going to be a various cascade of reactions which are going to occur. So what will happen is that you will have degranulation of the mast cell, and also on the other hand, there will be calcium influx within that mast cell, right? So this end, you see over here, there's a granule release, and then the granule basically contains histamine, proteolytic enzyme, heparin, chemotactic factors, basically the preformed mediators. They are responsible for the acute phase of allergy. However, on the other side, what is happening is responsible for the chronic phase of the VKC, right? This is something which is responsible for making the vernal keratoconjunctivitis a chronic disease, right? So what happens is that here there will be calcium influx, and because of that calcium influx, ultimately there will be activation of phospholipase A2. Now this activated phospholipase A2 is going to act on the arachidonic acid and is going to, this arachidonic acid is now going to enter two pathways. One is cyclooxygenase pathway and the other one is lipooxygenase pathway. The lipooxygenase pathway is responsible for production of leukotrienes, and the cyclooxygenase is responsible for production of prostaglandins, prostacyclins, and thromboxanes. Now, when we are talking about the topical NSAIDs, we are talking about the inhibition of this arm, that is the cyclooxygenase pathway. And moreover, here it is basically the prostaglandin E2 and I2. So let's have a look over here. So phospholipids in the membrane will basically, over here you see phospholipase A2 will get activated. It will break down this phospholipids into arachidonic acid, and then you will have it converted into prostaglandin G2, H2, and ultimately all these things. E2, D2, F2 alpha form what is known as prostaglandins. I2 forms prostacyclin, and TXA2 and B2 are thromboxanes. Now, your topical NSAID is going to act on your prostaglandin E2 and prostaglandin I2, and they are the one which are responsible for all the itching and the redness response in VKC. Okay, so that was your topical NSAID. I hope that is clear. Now, when we talk about steroids, steroids are something which is going to act both on the early phase and also on the late phase of the allergy, right? So making them more advanced than the topical NSAIDs. Moreover, the stinging sensation is absent in steroids. So steroids are going to so basically what does it mean? It means that they are going to inhibit the inflammatory cells from coming into circulation. They are going to inhibit the mast cell proliferation. They're also going to inhibit various immune responses, production of prostaglandins, leukotrienes, and also the platelet activating factor. So seems like a magic drug, right? However, the problem with steroid is that there are going to be serious side effects. That means they are going to cause increased intraocular pressure, leading to steroid responsive glaucoma. They can lead to cataract formation with long-term use. They can delay the wound healing. They can be increased risk of viral and fungal superinfection also. So whenever you're using steroids, you have to be really careful while using steroids. So what are the steroids which are available to us? So we have low potency steroids and high potency steroids. Okay, so let me tell you that the low potency steroids over here are the loteprednol etabonate. Then we have fluoromethalone and remoxilone. Now the most common one which is used and which can be titrated very well is a loteprednol etabonate. Usually these are started at 4 times in a day, and then you keep on tapering them over a period of 2 months or 3 months, right? Then we have high potency steroids. These are the prednisolone available as acetate formulation. We have dexamethasone, and then we have difluprednate. Difluprednate can also be given as once daily dosing, right? So remember these low potency and high potency topical steroids which are available for treating VKC. One more fact I want you to remember is that high potency steroids, although they have high potency, they also causes greater side effects. That means the side effect of causing raised IOP and cataract formation is much more common with high potency steroids compared to the low potency steroid. And that is the reason why mostly we start the patient on loteprednol and not really with prednisolone. So you always start small with the steroids, and if needed you go ahead with high potency steroid, but then again you have to taper the steroids gradually. Never ever stop your steroids suddenly. Always taper them before you stop the steroids. And if you sense at any moment that the patient is becoming dependent on steroid, or the patient's allergy is coming back immediately as you are tapering the steroid, it means that your patient basically has steroid dependency, and such a patient might need long-term chronic inflammatory control, and those patients are ideal candidates for topical immunomodulators. Okay, so in our advanced video, we're going to talk about in detail on how to use steroids and how do you basically prescribe immunomodulators. Now, anyways, for this video, let's talk about the immunomodulators that we're going to talk here will be the calcineurin inhibitors, that is cyclosporine and tacrolimus. Okay, so I hope you understood exactly how the antigen is presented to the mast cell. Similarly, something similar happens in the T cell as well. T cell has this T cell receptor, and you can see this MHC molecule which is carrying the antigen is presenting the allergen or antigen to the T cell receptor, right? So these immunomodulators basically are immunosuppressive agents, and they're going to specifically target the T helper 2 lymphocyte pathway. What did I tell you? The T helper 1 pathway is basically inhibitory pathway, so it kind of protects you from allergy, whereas T helper 2 lymphocyte pathway is responsible for the allergic response per se. Right, the drugs here are cyclosporine and tacrolimus. So you can remember their percentages: 0.05%, 0.1%, tacrolimus 0.03%, and 0.1%. Usually tacrolimus is used for long-term maintenance therapy. So let's see the mechanism of action in detail. So initially, as the allergen is detected by the T cell receptors, what happens is that there will be triggering of an intracellular signaling, right? And at this point, there will be phospholipase C activation. This phospholipase C, once it gets activated, there will be release of calcium from the intracellular stores. Now, this will lead to this released calcium is going to now bind to this molecule over here that is known as calcineurin, and this calcineurin is basically a calcium dependent phosphatase, right? So initially T cell receptor gets activated, phospholipase C gets activated, so calcium release is triggered from the intracellular stores. As the calcium levels within the cell rises, the calcineurin is activated. This calcineurin is a calcium dependent phosphatase, right? Also, at this point, you can see the calcium, calcineurin, and immunophilin complex is going to be formed. Right now, this calcineurin is a phosphatase, I told you, right? So it basically removes phosphate basically from this NFAT. NFAT stands for nuclear factor of activated T cells. Once this nuclear factor of activated T cell is basically activated, it goes into the nucleus and it causes upregulation of cytokine genes, and all these cytokine genes are responsible for allergy. But if you can somehow inhibit this calcineurin, which is responsible for the dephosphorylation of this nuclear factor of activated T cell, then you can basically prevent this upregulation of cytokine gene and you can prevent the allergy as well. So here we have these two drugs. One is cyclosporine, another one is tacrolimus. Cyclosporine basically forms a compound with cyclophilin and then it inhibits calcineurin, whereas the tacrolimus basically binds with FK binding protein and then it is going to come and attach itself to immunophilin and thereby also inhibiting what is known as calcineurin. So ultimately, as you inhibit calcineurin, the cytokine expression is going to go down. So interleukin 2 is going to go down, T helper cell 2 response is going to go down, interleukin 4, 5 and 13, all of these responsible for allergies is going to go down, right? So calcineurin inhibitors, cyclosporin and tacrolimus, they are going to block the activation of calcineurin and therefore there's going to be inhibition of the T cell activation. Mainly the T helper cell 2 response is going to go down, inhibiting the chronic inflammation in VKC. So we can say that the immunomodulators can also help in basically decreasing the chronic inflammation in case of the VKC. Also, it inhibits interleukin 2, so T cell proliferation will go down. Again, pro inflammatory cytokines like 4, 5, and 13 will go down. Alright, so I hope that is clear. Now, let's talk about some of the biologics. And first of all, we have the IgE inhibitors. We know that Ig is something responsible for binding with the allergen and also it binds on the surface of your mast cells. So, if you can introduce some IgE inhibitor. In this case, we have omalizumab. Now, this is given subcutaneously. Okay, so it binds to the free IgE and it prevents the IgE from binding to the receptors which are present on the mast cell and basophils. These receptors are Fc epsilon Ri. Okay, so it prevents the IgE from binding with these receptors and therefore it brings down the inflammatory response. The only problem with IgE inhibitor like omalizumab is that it causes pain at the injection site. Now basically it's a monoclonal antibody because it is acting against IgE, right? So this is given subcutaneously and the problem is it causes pain, it can cause headaches, pharyngitis, upper respiratory symptoms and sinusitis. Not all the patients can basically accept this IgE inhibitors, right? All right. Apart from that, we have other biologics available as well. So they are going to be acting against various other interferons and various other, you can see interleukins over here. So the most common one is the dupilumab. Now, this is a biologic that targets basically the interleukin 4 receptor alpha subunit, and basically by doing that, it brings down the pathways responsible for interleukin 4 and interleukin 13, which are the key drivers of type 2 inflammation, right? So, they will thereby they will decrease the eosinophil levels. The only problem with these biologic is that they can cause side effects. Patient tolerability is low. They can cause dry eye and conjunctivitis as the side effects. All right. Apart from that, we have various other biologics available as well. You can go through that. Not very commonly used. So we discussed about the topical treatment, systemic treatment, oral antihistamines. When do you give? Basically, the patient has a systemic atopy as well. Oral steroids very rarely given along with the topical. Oral immunomodulators again given in exceptional cases, really refractive cases. Usually we go with topical immunomodulators, right? Now let's talk about the surgical treatment of VKC. This is resorted to in case of refractory papillae and ulcer in case of the VKC. The first one we have is a supratarsal corticosteroid injection. This is done in case of severe refractory VKC, as I told you. The drug that we use here is triamcinolone acetonide. Also, here the patient might need re-injections, and the only thing is that this can be used as a supplementary therapy along with the topical corticosteroids. So how do we do it? Basically, it is done under local anesthesia. You basically invert the upper eyelid, use a 25 gauge needle, and initially local anesthesia with 2% lignocaine is given, followed by 20 milligrams of triamcinolone acetonide. This is available as a 40 milligram per ml suspension, so you can adjust the dosage accordingly. And the injection is basically given in the supratarsal space between the conjunctiva and the Muller's muscle. So this is your tarsus. So the injection is given 1 mm above the tarsus in the supratarsal space. So somewhere here you will have your Muller's muscle, conjunctiva, and then you have your Muller's muscle. So in between that space, you inject your triamcinolone acetonide. Alright. Apart from that, the other treatment options for refractory giant papillae is cryotherapy. We can also do surgical excision of papillae. So basically, surgically, these papillae might be removed. Then you get a bare area, and you can actually cover that bare irregular area of conjunctiva with amniotic membrane graft. The amniotic membrane graft itself has some sort of immunosuppressive capabilities. Now, when we talk about mitomycin C usually in the dosage of 0.02%, it has an anti-fibrotic property. Now, what happens is that because of the constant inflammation and fibrosis, these papillae are formed. So, after surgical excision, it is believed that if you inject mitomycin C, there will be less fibrosis and there will be less chances of recurring papillae post-surgery. Okay. Apart from that, sometimes we do superficial keratectomy. Superficial keratectomy is basically a procedure wherein you are going to remove some part of your cornea, right? That's why it is known as superficial. It's not superficial because you are removing the epithelium and some part of stroma. So that area of the shield also where you have the plaque, so you can do superficial keratectomy and remove all that debris and inflammatory material, and this will cause smoothing of the base of the ulcer and the sides of the ulcer. Okay, so that is superficial keratectomy. The same thing if you are doing using an excimer laser. Okay, that is known as phototherapeutic keratectomy. The whole idea of doing this keratectomy is to remove the inflammatory cells which are sitting at the base of the ulcer. Also, when you do that, you can also freshen up the margins of the shield ulcer. This will basically help the corneal epithelium to grow nicely over the shield ulcer. Also, by doing phototherapeutic keratectomy, you can smoothen out the superficial corneal irregularities caused by the chronic inflammation, and ultimately it will help the patient in improving his corneal transparency and vision. Let us briefly talk about the stage-specific treatment of VKC. The treatment for shield ulcer is totally separate, and that would be talked about in the advanced video. Initially, in case of milder cases, lifestyle modification like starting with cold compresses and avoiding of the allergens is advised. As first line therapy, you can give the patient lubricating eye drops, and along with that, you can prescribe them one antihistamine or mast cell stabilizer like Olopad. Now, usually, basically, the dual acting agents are considered ahead of the monotherapy with antihistamine and mast cell stabilizer. The patient usually responds well to this conservative approach. However, in case of moderate VKC, what you do is you will basically continue with the same treatment, that is mast cell stabilizers and antihistamine. But what you can do is you can basically increase their frequency if needed, and then if needed you can add a short term pulse therapy with topical corticosteroid. Here you can use chloromethadone or lotiprednol for short term use and to control the inflammation. If the patient is not responding well, or if you sense any steroid dependency, then what you can do, or if there's steroid resistance, you can consider prescribing a topical immunomodulator like topical cyclosporine 0.05% or 0.1%, and you can also use tacrolimus 0.03% either as solution or as ointment. These are basically the steroid sparing agents for long term control, especially in case of chronic cases. Also, at this point, regular follow ups are really critical to monitor the side effects of steroids like the increase in intraocular pressure. However, when we talk about the severe VKC, here you can start with high potency topical steroids like prednisolone acetate 1% or dexamethasone, but you have to use them for the shortest duration possible under really close supervision. Then you might also want to intensify your treatment with cyclosporine A. Over here you can straight away go with 0.1% or tacrolimus ointment. They are excellent for long term control. And if there's shield ulcer, you have to manage accordingly with the antibiotic drops, maybe some surgical debridement, and also amniotic membrane graft, conjunctival grafts, and bandage contact lenses. If there are papillae formation, you can treat them with either surgical excision, amniotic membrane graft again, or you can use supratarsal injection of the corticosteroid like triamcinolone. In very refractory cases, systemic therapy with your oral antihistamine and oral steroids might also be used. Right, so this is basically a stepwise approach. So at every step you wait for 2 weeks and you monitor the response, you monitor for side effects, and then you escalate your treatment. Also, if the patient is responding well to your treatment and if the patient is stable for 6 months to 1 year, then you start de-escalating the treatment as well. Right, so it's a step ladder approach based on the disease severity. Patient education is something that is expected from you. So VKC is a chronic recurrent condition which is going to usually improve with age. So this is what you're supposed to tell to your patients and also their attenders. Also advise them that rubbing of these itchy eyes can make the condition worse, with advice on a no touch zone. Okay, then sunlight, wind, salty water, dust and heat, all of these can exacerbate VKC. So advise your patient to use sunglasses, hats with visors, swimming goggles. All of these have to be considered. If possible, an air filtration system in the home can basically provide relief. Common allergens can exacerbate VKC, and therefore frequent washing up of hands, face and hair can reduce exposure to these allergens and bring down the symptoms of VKC. Cold compresses, preservative free artificial tears can also provide symptomatic relief. Another thing is adherence to the treatment. So make sure that you educate your patient well, so that patient doesn't go on for doctor shopping and keeps on changing his medication. Whatever treatment is advised, the patient has to adhere to that treatment very well, and also he should be aware of the risk which is associated with the long term use of corticosteroids specifically, so that they don't self medicate with the steroids, because this can lead to vision threatening glaucoma and cataract development. Okay, so that was a beginner's guide to VKC treatment. I hope that was useful. Thank you for watching. Thank you and have a nice day. A detailed video on VKC treatment, on the advanced concepts of treatment, would be available at the Loyal Insider membership level. Thank you for watching. Have a nice day.